Assalamualaikum warahmatullahi wabarakatuh. Selamat malam dokter semuanya. Good evening doctors, anywhere you are. Welcome to another webinar from PainManagement.Network. My name is Kansa and this is Lala. We are tonight will be your moderator for webinar. Thank you for joining with us tonight. We hope we can have a good discussion and deepen our understanding on pain management.
Okay, thank you, Dr. Kansa. So happy to join you here. Okay, so tonight we are going to talk about the topic of curing the pain. It's the second webinar as introduction to our next course, which is for non-interventional physicians. Okay, Before we start, let me introduce our speaker for tonight. Of course, our dearest Dr. TCT Novy. Let me read the curriculum vitae. Dr. TCT Novy, MD Physiatrist, MS, FIPP, CIPS. She is the Director and Physiatrist and Pain Specialist in Bandung Pain and Rehab Center. And also she works in Bandung Adventist Hospital Pain Clinic. And also she is the Program Director and Lead Researcher in PainManagement.Network. She had her GP education in Universitas Pajajaran Bandung, and then she continued her study as physiatrist in Pajajaran University, and then she had her competency in IPM-USD, FIPP, and CIPS in Netherlands on 2017. And then she's also active in various organizations as like World Institute of Pain, where she is the member and also the credential examiner. Also the director of World Academy of Pain Medicine Ultrasonography Chapter Indonesia. Also in Perdini, Indonesian Society of Interventional Pain Physicians, and more. And this is our clinic, Bandung Pain and Rehab Center. Maybe doctors can visit us someday here. We are also going to open the new clinic, right?
Yeah, we are going to have 2 pain clinics. The first one is in Cipaku in the Tiga, and the next one will be really soon.
Okay.
It's still
coming soon.
Coming soon.
And these are our social medias, our Instagram, our Facebook, and YouTube. If you want to know more about our events and our activities there, so yeah, you can follow us there.
Okay. So, before we start our webinar tonight, I want to let you know that we have several programs on Pain Management Network for this year. Closer one is Outpatient Pain Management in High Prevalence Cases, is FIPP. So tonight's webinar and last week is the introduction before the FIPP pain management for non-intervention physicians. We will have 7 webinars in April, from 24 April until 30 of April, from 7 p.m. until 8:30 p.m.
1 more month.
Yeah.
So, what doctors can follow this course, Dr. Kansa?
So who can follow and join this course is general practitioners and any kind of specialist who wants to know and to learn more about pain management, because this course is made for use. You can use it in daily practice. Yeah, because every doctor must have a patient like come to the clinic to then tell that they have pain. So this is very important, I think.
Okay, and what will I study if I join the course?
So you will learn about providing solutions. So this is about the pain management basic, managing musculoskeletal pain, managing pain on head and neck, managing spinal problem, cancer and stroke pain, pharmacology of pain drugs, and managing autoimmune and widespread pain.
7 webinars in 1 week.
Yeah.
Wow.
7 webinars in a week. in a row. And the next one, this is our first international program. This is our virtual conference. It will be on 10 until 11 April. So it's Saturday and Sunday. We will have 45 speakers from 14 countries that will talk about pain management and current updates about pain topic.
Okay.
Who can join?
Mm.
Who can join this conference? Anyone. Anyone who wants to know more about pain management,
Mhm.
you can join with us.
There's so many
Uh,
topics we're gonna talk about.
Yes, this is some of the topics that will be discussed on the conference. We will have how to prevent recurrence of pain, ethic in pain management, multidiscipline pain clinic, management of lower back pain, online workshop of ultrasound guided on IPM on spine, cluneal pain, thalamic pain, and so on.
Okay.
Then the next one, we will have basic ultrasound guided interventional pain management on musculoskeletal will be on 24th of May until 29th of July. This is all the program will be online every Monday and Thursday from 7 p.m. until 8:30 p.m.
So from May to July, we will have course for every week, two times.
Every week, 2 times a week.
Okay. So this is the course for ultrasound learning, right?
Yeah.
Can I, as a GP, join this course?
Okay. Basically, everyone can join us,
Mhm.
but because in Indonesia, the government regulation that who can legally do the intervention is only from 5 collegium. So I think for Indonesia, this is only for specialists like from anesthesiologists, physiatrists, orthopedists, neurosurgeon, and neurologists. So, but if you are from abroad, you can anyone who can join us. If in your country it's legal to do the intervention.
Okay. So what are we going to learn?
This is we will learn about US guided IPM on shoulder, elbow, wrist, and hands, on IPM on hip, knee, ankle, and IPM drug pharmacology and regenerative medicines. And the next one, this is intermediate ultrasound guided interventional on pain management on nerve.
Mm-hmm.
So this US ultrasound guided course will more deeper. Before the basic is about musculoskeletal, and this will talk about the nerve. So this is also 3 months. That's why it's called 3 MLP, 3 months learning program. It will be on Monday and Thursday every 7 until 8:30 p.m. The topic is like, as you can see on your screen, brachial plexus, lumbosacral plexus, lower extremity, IPM on chronic pain, and radio frequency. And the last one, our program is the newest program in PainManagement.Network is Adventist. This is ultrasound guided interventional on pain management on spine. So it's from 11th of October until 16 December. The topic is so interesting, like spine anatomy and ultrasound guided, IPM drug pharmacology, ultrasound guided IPM on lower back. We will have 3 parts because it's a lot of theory, and we will also have thoracic spine and neck.
Okay. So that's a year full of learning.
Yeah.
Yeah. Okay. So getting to the center of this webinar, curing the pain, I want to welcome, of course, our lovely speaker for tonight, Dr. Novy. How are you, Doc?
Very fine, very good, thank you.
Looking so pretty.
Great today. Thank you. Yeah, too. Thank you for the warm welcoming speech from both of you, Dr. Kansa and Dr. Lala. So, good afternoon, good evening to all of you, our dear colleagues from all over the world. Very nice to see you again tonight. Tonight we are going to learn more about pain. This time in the FIPP course. FIPP means
For non-intervention physician.
okay. So this course is dedicated to non-intervention pain physicians. Means that if you are not intending to do interventional pain management, you are welcome to learn more also about the pain management. But if you want to learn more about interventional pain, second topics in the FIPP course is curing the pain. Curing the pains means that we are trying to heal the patient from their suffering from pain. The treatment of pain actually follow the step-ladder treatment of cancer pain using WHO step-ladder pharmacological treatment, such as this. Here in the screen, you can see there are several steps which actually consist of only the first, the second, the third, and the fourth stage of pharmacological treatment without the operation, of course. So means it only has 3 stages, which are the first stage is only non-opioid medication. The second stage is NSAID plus or minus weak opioids, and the third stage consists of the first and the second stage, maybe using strong opioids. Okay, in the whole management of pain, it's not enough. So there is the 0 stage, which consists of non-pharmacological methods that includes rehab, conservative treatment using modalities, exercise, and other rehab stuffs, and also in the view of patients include also resting, because when we have pain, if we don't let our patient get enough rest, then the inflammation and the pain will continue, means that the healing process will be not so fast as if the rest is given to the patient. If we have pain patients, we always usually starts with the non-pharmacological methods. Means that if our patients has already relieved from their pain using resting, it's enough. We don't need to go to the further stage. If the patients has already relieved from their pain using resting and rehab conservative treatment, means that maybe they don't need the next step also. But if the pain persists, we must think about the next step. The nearest step is non-opioids, means usually it's paracetamol. Paracetamol is the weakest painkiller that can be given to the patient, which has the least side effects than other medication, but give good results, good enough for certain pain condition, severity, and duration. If then the pain is still there, we may add NSAID. NSAID means that you can give ibuprofen, natrium diclofenac, or celecoxib. Depends on the severity and the duration and the comorbidity that is there in our patients. If the patients resolve from the pain, means that we must reduce the medication either abruptly or slowly, depends on what medication you use. Then the patient will be happy because the pain is not there anymore. But still, we must remember about the 0 stage where rehab is. Because then if the pain is not there anymore, if we don't give the patient at least the vision, the education, the knowledge about what they have to do to prevent the recurrence of the pain, then the pain may be coming soon. So this here at the left side, there is preventive and promotion and prevention treatment to help the patient getting rid of their pain. Okay, but then back to the second stage, if then the pain is still there, for example in cancer pain, we can give strong opioids for the patients. But what if the pain is still there, and what if the pain is still there and operation cannot be done to help the patient? The patient will be in a miserable condition. How to be recover from the pain? So there's a gap between the 0, the first, the second, and the third stage with the operation, where the patient can get rid of their pain using IPM. IPM is interventional pain management that maybe can help the patient to recover. Okay, and all the way from the 0 stage to the recovery stage, rehab must be there. Rehab must be there, and also the promotion and prevention treatment should be there also, so then the pain will not come back again. Okay, this is the whole way of thinking on how we treat our pain patients. And this is my favorite image to be shown to our patient, and now I want to share it with you also, because using this pain assessment tool, this is numerating rating scale. If you don't know, then I hope you know it already, but maybe you don't use it in your daily practice. This is the pain assessment tool where there is a 0 to 10 scale, which means the severity of our pain patient. Okay, 0 means no pain, 10 means the worst pain possible that will be suffered by us. I usually make analogy to the patient, such as if a mother try to deliver a baby, but it's not cesarean one, and it's not a nice, easy delivery one, and it needs a hard effort to deliver her baby, and it's very painful. This is the worst pain possible. And if there is 0 and 10 scale, means in between there is 1, 2, 3, 4, and so on pain, where 1 means that the pain is light, and at that time the pain is no more anymore. Okay, so then if your patient suffer from the 1 score pain in the scale of 0 to 10, means that the pain is no more, means that the patient doesn't need to be worried about how to treat their pain, because the pain is not there anymore. But then if the pain is increasing, it can become 2, 3, or 4. 2 means that it is a bit stronger than 1, but suddenly at that time the pain is no more. So means, again, no need to be worried. You have no more pain, means that you don't have to think about what should I take to relieve my pain. But the pain is then become 3, so the severity may be just like 1 and 2, but it is continuously felt by the patient. Means that at that time we see downward. This is the step ladder of pain management. So the patient has 2 steps. Non-obat in bahasa means non-medication, non-medication that consists of rehab, conservative treatment, or resting. So once you have the severity of pain in 3, means you have to take a rest. By taking rest, hopefully your pain will be gone. If the pain is still there, in 10 seconds time, wait to 30 seconds or 1 minute for maximum.
If the pain is still there, please use the step 1. If you don't have any contraindication to take paracetamol, paracetamol is the safest medication to heal your pain if the severity is only 3. But if the pain is already not there, using resting means you don't have to take any medication. Just be happy and continue your activity. Resting means not only bed rest. If I'm sitting like this and I have pain in my lower back, try to change position. Change to lean to the right or to the left, forward or backward. If the pain is still there, try to stand up or walk. If the pain is still there, the best treatment resting is by laying down. Okay? If the severity is only 3, by changing position, usually the pain is no more, because in every position there's certain bone, certain joint, certain muscles that support our body. By changing the position means that the muscles, the tendon, the ligament, the muscles, the bones, then the joints have been changed to other positions, means that the part that is hurt, that is in pain condition, has no burden anymore, means that there's somebody opening their mic. Okay, thank you. Means that the burden is changed to other positions, means that the pain will be not there anymore. Can you get it? So resting doesn't always mean taking a rest, bed rest, not always. Okay, by changing position, hopefully the pain will be gone if the severity is only 3. If the pain is still there, maybe the pain is already comes to the 4 score, means that you need at least paracetamol. If then you've already consumed the paracetamol, depending on your body weight, you can take 3 to 4 times 500 milligrams or 750 or even 1,000 milligram, and the pain is still there for 3 days, or the pain increasing before 3 days, please visit us, means your doctors, because then at the scale of 4, 5, 6 and so on until 10, you need doctors where they maybe give you the step 2, step 3, step 4, or even the operation step to get rid you from your pain. So by using this simple pain assessment tool and this simple step ladder of pain management, we can educate our patient how to treat themselves without going to the doctor and get rid of the pain. But please remember also to educate our patient, if your pain is already in the score of more than 3, please visit doctors. By doing this, hopefully we can make the world a better place for our patients to be healthier and be happy without having to have having a lot of suffering from pain. Okay, about the IPM can be done after the steps is followed, or jump to the first step if the pain is so severe at the first visit. But usually the steps should be followed such as this. Okay. Now this is how to cure the pain. I want to show you some cases. Hope the time is enough. The first case is about a female of 46 years old who is a housewife with chief complaint pain at her left hip, which is referred to her bilateral calf since 7 months ago. Okay. There's no history of disease or trauma and drug consume. For the hip pain, right? Left hip pain, she has already got acupuncture treatment once a week for 7 months, but she's still in pain. And she went to a neurologist who said that she has a spine pinch nerve. From the subjective, from the anamnesis, from the history taking, the pain at the left hip refer to the calf, the right calf and left calf since 7 months ago, and the pain is on and off, means sometimes there is pain, sometimes there is no pain, and when there is pain, she can't even sit for 2 minutes. There was no numbness, there's no tingling sensations. There's tingling sensation sometimes at the left calf. There's no disturbance in defecation and urination. Sometimes she can't sleep at night because of the pain. The numerating rating scale of her pain is between 4 to 5 in the scale of 0 to 10. The differential diagnosis from history taking at that time for me, the first is piriformis syndrome. Piriformis syndrome, can you get it? Piriformis syndrome because the pain is felt from the hip to the calf. Okay, and then foraminal stenosis lumbar. Why foraminal stenosis lumbar? Foraminal stenosis usually used to note the stage of the suffering caused by the stenosis of the foramen, but actually the symptoms count, means that there is radiculopathy. Radiculopathy because the symptoms radiate from the hip to the calf. Okay, so there's another differential diagnosis, and then it can be caused also by sacroiliac arthropathy because the sacroiliac joint is at the back of our back. You can see here. I think that one, yeah. If you see here, can you see it? This is back of our lower back. This is the lumbar spine, and this is the ilium, the real size. This is the sacrum. If I use the small mannequin here, okay, this is the same. This is the lower back area. This is the ilium, and this is the lumbar spine, and this is the sacrum. This is what is called sacroiliac joint. Okay, the sacroiliac joint pain can radiate to the thigh and to the calf also. So the next differential diagnosis is sacroiliac arthropathy. Okay, there is some of the differential diagnosis. So by thinking about the differential diagnosis got from the history taking, I want to do the physical examination. The physical examination always start with the vital signs. The vital signs is within normal limit, and because the complaint including the back, I start with the back. The patients always come to us walking, right, or in wheelchair or in a stretcher. We must do the look, feel, move examination. So when we let the patient enter our room and they walk to our room and they sit, so we must examine them in the sitting position. In the sitting position for the low back pain, we can ask them, since they were examined during the history taking, ask them, is there pain when they sit? The sitting position has no pain. The patient felt okay. And then I asked her to stand. In the standing position, there's no pain also, means okay. And the changing position from the sitting to standing is okay also. Why I do this? Because changing position for joint pain usually causes pain in the changing position. So by doing this, I know that hopefully there is no joint problem. Okay, and then from sitting position, I ask her in this case to walk. From standing position to walking position, there's a changes also, right? There's no problem in the changing position. And while walking, she's okay, but there's tingling sensation on the left calf, but only minimal. Okay, so from this first stage of examination, I know maybe this piriformis syndrome or foraminal stenosis. Okay. Then I examined her while she was standing. There's pain on movement at the hip when she was asked to do hip extension. Okay, hip extension. If I stand like this, please camera. This is my hip, right? Am I there on the camera? Kansa, tolong. Okay. Okay. This is my hip, right? If I do extension, means I do like this. Okay, this is extension. This is flexion. Okay, this is lateral bending to my left. This is lateral bending to my right, and this is rotation to the left, and this is rotation to the right. By doing so, I know what might be the cause of the pain. Okay, she felt pain when the hip extension is done at the left paravertebral lumbar area. And at the other direction, she only felt stiffness. Okay, so then I continue with other position in lying down position. She felt pain only when she lied on her left side and still at the paravertebral lumbar area at the left side. So maybe it is piriformis syndrome, maybe it's still sacroiliac joint pain. Okay, some of you maybe agree, some of you maybe not agree, but this is how we assess our pain patient, especially me, okay? And then when she lied down, I put some pressure on her back and there's no pain on pressure at her back. Okay, and then I do lower back maneuver. Lower back maneuver, there's a lot of lower back maneuver. This is what I usually do in my daily practice. Straight leg raising test. Left and right was negative. Braga, Thomas test, Patrick, contra Patrick, piriformis test, hamstring test, all were negative. Okay, and because there's a differential diagnosis of foraminal stenosis, I check for the sensibility. L2, L3, L4, L5, S1, all 10 both sides. I usually use the scale from 0 to 10 because in the evaluation in the future times, I need to see whether there's changes of sensoric or not. Okay, so both sides is just the same. You can use usually +2, right? I use 10/10. Okay, both sides is just the same, 10. But the motoric from the L2 till S1, there's decreased except for the L4 and L5. Both sides is 5, full strength, but the L2, L3, 3 both sides, the S1 is 4. Okay, so means maybe there is something with the radix of L2, L3, and S1. So we come to the differential diagnosis again. From the history taking, we have 3 differential diagnosis. Now after we do the physical examination by doing look, feel, move, I have differential diagnosis also. The first is piriformis syndrome, left side, maybe both sides. And then the second one is foraminal stenosis, both sides, L2 till S1, bilateral also. And then sacroiliac joint arthropathy, the left side, although the lower back maneuver is all negative. Okay, so then I always do this. Do I need supporting examination? What kind of examination that I need? On which area? And what should I see in the supporting examination? What do I expect from the supporting examination? If I don't need any supporting examination, I usually do not ask the patient to do it. Okay? Then, without doing any supporting examination, I come to my working diagnosis. The first one is piriformis syndrome, the left side. Okay. Although there's still chance of another differential diagnosis, such as sacroiliac joint arthropathy or foraminal stenosis with radiculopathy, which involve the motoric without the sensoric involvement. Okay. Now, I want to treat the patient if I have working diagnosis. Before I treat the patient with the diagnosis, I always have the problem. You have always have the problem, right? So this is the problem. The problem is the first is pain, of course, and vocational, because the pain make the patient cannot work, cannot sleep. Okay. So the goals. This is just like usual stuff, but please put in mind that we must relieve the pain from the patient, and then get the patient back to their work, get the patient to their usual activity by reducing the pain, so we can increase the quality of life of our patients. Okay, so the program is, at the time, I give her only pacing management education. Means that I educate her how to rest when the pain is there, because the pain is on and off, right? And because the pain is still there at the time she visited me with the severity 4 to 5, right? If I am not wrong, 4 to 5 in the severity scale of 0 to 10. So I give her celecoxib. This is NSAID. The body weight is only 35. So 100 milligram, I hope, is enough for her 2 times a day. And because the pain is already suffered for 7 months, usually the back muscles is tight. I gave her muscle relaxants once a day, and mecobalamin 2 times a day. Is just B1, B2, B3, B4, B6, B12 vitamin. And I asked her to come back in 1 week time. In 1 week time, when she visited me again, the pain on the left hip is already reduced. It's that simple, right? Simple, but make her happy. Sometimes there is tingling sensation on the left calf, but no numbness. So she's happy, I am happy also, but we must make sure of the symptoms, right? So again, there's physical examination, the vital sign is within normal limit. At the back, while sitting is okay, standing is okay, changing position is okay. While walking, okay also, but there's still tingling sensation on the left calf. There's no pain on movement. Previously, there's pain when the hip is extended. Now, no more. And in the lying position, there is still pain on the left side when she lay down on her left side. In the paravertebral lumbar area, the left side also, but already minimal. There's no pain on pressure. And then again, I do the examination, but after doing the examination, I provoke the patient with exercise. Why I provoke the patient with the exercise? Because the pain is already reduced. I want to know whether if I give her simple exercise, the pain is there, means I have to maintain the medication. But then if the exercise has no effect on her, that means that she's okay, she's fine with a higher burden to her, means that I can reduce the medication. Okay, so then the differential diagnosis now, piriformis syndrome is healing now. Okay, foraminal stenosis might be there because there's still tingling sensation in the left calf. L2 till S1, because from the motoric examination, there's involvement of L2, L3 without L4 and 5, but S1. Okay, there's no sacroiliac joint problem. So the problem is again still pain, although it's already reduced, vocational, and the goal is to reduce the pain and to increase the quality of life. So the problem still again, pacing management education. I maintain the celecoxib and celecoxib only, but I add methylprednisolone 4 milligram 2 times a day. Why? Because there is diagnosis of radiculopathy because of the foraminal stenosis, and I want to push the medication as full as possible to see whether if I use the maximum medication, the symptoms will be reduced. But I add the William flexion exercise to her to see whether if I use the full dose of medication, the symptom is still there. Okay, and I use pregabalin 50 milligram once a day for the tingling sensation, and I ask her to come back in 1 week time, and in 1 week time she comes back, no pain on the left hip, no numbness, no tingling sensations. Yeah, quite good. The vital signs was within the normal limit at the back, while sitting, standing, walking, okay, no pain, but let's see whether there's still tingling. Okay, no pain on movement, and on position there's still minimal pain felt when she lied on her left side. No pain on pressure when exercise is given to her. She was okay. So then the differential diagnosis still piriformis syndrome, left side improving, healing on progress, and foraminal stenosis improving also. The problem is just the same, but all is already quite good. The program again, pacing management is always be given to the patient. Celecoxib is stopped, okay, because there's no more pain. Pregabalin is stopped also. Methylprednisolone is tapering off now. Exercise is given. Follow up in 1 week time, and in 1 week time, there's no pain, no tingling sensation, no numbness. Okay, I was happy. She was happy. In the physical examination, all is fine. No pain on movement, no pain on changing position, no pain on pressure, no pain while she did the exercise. So the differential diagnosis, piriformis syndrome healed, piriformis syndrome, foraminal stenosis improving. Still, the program must be given to the patient to do pain management. The methylprednisolone now has already stopped. The exercise is continued, done by the patient. The mecobalamin is continued, follow up in 1 week time. This is the video. Can you hear the sound? Ada suara? Can you hear the sound from the video? Because I cannot hear anything here. Okay, this is how she did the exercise at the examination room. What are you going to show to the participant here?
This is when the patient do the William flexion exercise without pain, doctor.
Okay, without any pain. Okay, and this, she sits without any pain, and then standing without any pain also, and then okay, this is just the process. Okay, so in 3 weeks time the pain is healed already, except for the foraminal stenosis to be followed up. So this is how I do the history taking, the physical examination, and how I treat the patient without any interventional pain management. So we must follow the step ladder management while doing the examination also, so we know how to treat the patient. Okay, if you have question, please feel free to ask. You can open your mic or you can write in the chat box to ask. Okay, is there any question already?
Yes. There is one question from Dr. Linda. Doc, based on your pain assessment tool and those steps, is it possible to skip 1 or 2 steps, like for Like for example, this patient has acute gastritis that cannot handle NSAIDs nor opioid. Hence, can we go straight to IPM? And is it possible to do IPM without other medication? Thank you in advance.
Okay, thank you, Dr. Linda. If you join us last week, I've already explained about how to deal with the pain patients by doing the step ladder. How do I go back to this one? Okay. The step ladder. Yes, sure. You can jump straight to the IPM step. Even you can jump to the operation stage if indicated. Okay. And I have mentioned previously also, if then I evaluate that I need to do the IPM at the first time they visited me, I will do it. How I will do the IPM at the first time they visit me, if then the pain is already suffered for more than 1 or 3 months, when it has already become chronic, or the pain is so severe that it needs to be cut straightly at that time without giving the patient too long to suffer from the pain, or if the pain is already suffered by the patient for longer time than 3 months, where the medication is already given in full dose, and means that the rehab and medication conservative treatment has already given in full dose, then without any improving of the pain, or if there is already side effects from the medication, means that there is indication to do the interventional pain management. Can you show us the previous slide of the previous session? Last week.
Okay, for any doctors who want to ask question, you can type your question in the Q&A box, chat box right here. And maybe if you want to have a live discussion with Dr. Novy, you can turn on your radio and turn on your voice and have a live discussion with us here.
Okay, wait a minute. If you don't have a question, okay. This is the last week's slides. This is stepwise approach of pain management. So always start with the rehab or medication. Can you see it? Okay. So to remind you again, 80% of pain cases already resolved by the patients by themselves without having going to the doctor. Why? Because just simple resting will heal them. Only 20% will need doctors. Only 20% will need rehab and medications. And only 1/3 of the 20% case will need interventional pain management. Okay, so be wise not to give too much medication, not give the patient interventional pain management at the first time if this one. There should be something here. Okay, this one. When interventional pain management is needed, if the pain persists for longer than 1 or 3 months of optimized pharmacotherapy or rehabilitation, or there is already intolerable side effects to drug therapy, or there is aversion to taking long-term medication, or if the pain has to be given surgery, but they are not suitable for surgery. So it is indication for IPM. So it means that if the patient comes to you after they suffer the pain, for example, 4 months, maybe they are indicated to be given interventional pain management if they have already got optimized pharmacotherapy or rehabilitations. Or they come to you in 1 month or 2 months, but they already suffered for example, gastritis, or the blood pressure increase because of the celecoxib treatment, something like that, or there is already obstipation or constipation because of the opioid treatment, or the pain is still there because, for example, the patient have knee grade 3 knee osteoarthritis and has to be given operation, but they suffer for diabetes or high blood pressure that is not suitable to be given surgery, then the IPM is an indication. Okay, Dr. Linda, hope you now has a wider way of thinking about how we treat the patient using interventional pain management. Not always IPM is given at the first time. Maybe it has to be given later on, but it can be given at the first time your patient comes to you. Okay, but remember also, if there's a red flag, if there is a reduction of sensory or motoric component from the patient suddenly, and maybe they need surgery. Do not do rehab, do not give medication, do not do interventional pain management, just refer them to the surgeon. Okay?
But then the question from Dr. Linda,
Yeah.
possibility that the symptoms will be repeated, isn't it? How many percent it will be repeated, doctor?
There's a wide range of variety of the recurrence. You think about the recurrence here, right? Yeah. Okay, this one. For example, betul ya? Bukan.
Buka ini.
This one. If suppose I got COVID and I must get treatment in the intensive care unit, and thank God I am healed, and I go home after the second swab and I have no more COVID, can I open my mask? May I open my mask? No. Why?
Because you can get infected again.
Why?
Because the virus is still there.
Okay. So suppose I have piriformis syndrome and I am healed without IPM. I am healed by just getting celecoxib from Dr. Linda. Can I get the piriformis syndrome again?
Yes, you can, because maybe your activity make you can get the piriformis syndrome again.
Why?
You always use your muscle and your hip every day.
No, I asked Dr. Linda. Dr.
Oh,
Linda,
sorry. Dr. Linda.
yeah, can you open your mic, please? Can I suffer from piriformis syndrome again? Why? Why? No. If I have inflammation, so I must go back to this this slide of last week about pain. What is pain actually? pain is just a sensation, right? A sensation caused by either there is injury to our part of body, or maybe there is no injury, but because there's nerve involvement, the tissue damage is not there anymore, but we still feel the pain. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But this is the definition of pain by IASP in 1979. There is a revised definition of pain by the same IASP in 2020 by adding this one. Unpleasant sensory and emotional experience is still the same as previous definition, but there is associated with or resembling that associated with actual or potential tissue damage and expanded upon by the addition of 6 key notes and the etymology of the word pain for the further variable context. Means that if there is a tissue injury, for example, in the piriformis syndrome, there is tissue injury in the peripheral muscle that will cause inflammation there that will be felt by us as pain. Why there is pain? Let's go back to this one. If there is tissue injury, a moment please. If there is tissue injury, please remember about the pain pathway. The pain pathway. Okay, this one. Okay. If there is tissue injury, there will be nociceptive fiber in the peripheral nerves which will stimulate the peripheral nerve here that will deliver the sensation to the dorsal root ganglion here. You can see the cursor here. That will then transmit the stimulus through the spinothalamicus tract to the cortex, to the sensory cortex, that then the stimulus will perceived by us as pain. Okay, when the pain is there, then there will be modulating and descending tract that carries the pain that will reduce the sensation of the pain felt by us. Then we'll go back to the dorsal root ganglion. Okay, so this is how the pain travels. Okay, if we cut the pathway, for example, here at the peripheral nerves without treating the inflammation here at the tissue that is injured, then the cause of the inflammation, the cause of the pain will still be there. For example, in the previous case, I gave the patient pregabalin. Pregabalin works not here, but what works here is if you join the 4NIP course, there will be a pharmacology course of pain medication. You will learn more about how we treat the pain patient. If we give the treatment here at the site of the injury of the tissue, means that you are healing the source of the pain. But if you give the treatment here at the tract, means that you only cut the pain pathway but not the source of the pain. So if you give the celecoxib, you are trying to heal them. Celecoxib is a non-steroid anti-inflammation drug, right? So it works by reducing the inflammation that is happening here at the site of injury, means that the inflammation will be reduced, then the healing process will be happen here. Then without the tissue injury there, means there will be no more pain. So why I give the patient NSAID? This is the reason. But why I give the pregabalin? Because of the radiculopathy happens there. Radiculopathy happens because there is nerve injury because of this is nerve root. Okay, if nerve is damaged, then the myelin sheath will be disturbed. Once the myelin disturbed, there will be abnormal electricity impulses that will cause numbness, tingling, and so on. So the pregabalin will not heal the pain, but the NSAID will. So at the first time, I give the piriformis syndrome diagnosis with the celecoxib. I give the muscle relaxant to reduce the spasm at the back to help the reduction of the pain. I give pregabalin at the second visit because there is diagnosis of radiculopathy because of the foraminal stenosis. So that's the reason. So if the question is, will
Suaranya hilang, Dok. Bentar, Dok. Suara hilang.
can you hear my voice? Yeah. So if you say that I only I do masking effect to the pain, no, you are wrong. I must say sorry to you, you are wrong. Because what I do is I heal the source of the pain. I cure the pain, I cure the source of the pain, so the pain is no more there, means it is healed. Once I give, so for example, I give triamcinolone to the piriformis muscle that is inflamed, that is the source of the pain for the piriformis syndrome, then the steroid is not non-steroidal anti-inflammation. It is a potent anti-inflammation drug. So it will, at that time, will reduce the inflammation, will heal the inflammation, means that once the inflammation is not there anymore, the pain is healed, the source of pain is no more, mean the patient is healed. So it's not about giving masking effect to the pain, but the pain is no more there because the source of the pain is no more. Welcome. My pleasure. Okay, is there any question?
Question, Dr. Linda. I think our participants tonight is so on fire
Yeah.
to learn. We have another question from Dr. Muhammad Rahman.
Yeah.
Good evening, doctor. Is there any IPM management for post-herpetic neuralgia?
Stay tuned. Okay, we will
Stay
be
tuned,
there.
Dr. Muhammad Rahman.
Okay, I will show you the next slide. Is there any
Yeah, the
other question?
Oh yeah, we have some more questions.
There is case of post-herpetic neuralgia also. Soon. After
this question.
this question. Okay.
So the next question is from Dr. Stephanie. Good evening, doctor. Thank you for the great explanation. You're welcome.
Welcome.
Can I ask you how to educate the patient about the treatment that sometimes doesn't change their pain scale immediately? And how do we explain the patient that we need to change the therapy if the first therapy doesn't change the pain? Because sometimes it's hard for us to explain that it takes time to treat the pain.
Takes
Thank you,
time.
doctor.
Yes. I always say, sabar bu, sabar bu. Yes, sabar means be patient, madam. Okay, but let's see this one again. The step ladder. Not that one. This one, the complex one. Okay. Here. I always put this one here. This is my calendar. If you want to have it, please help Dr. Kansa or Dr. Lala to have it. Okay. Can you see it? Can you move? No, the chat. Okay. I have this in my examination room. You can have this also. You can make it such as this, okay? To make it easier for you to explain to your patient how the patient feel their pain, how it happens, and what are we going to give to the patient, okay? This one, can you see it? This is the pain scale as previously mentioned to you, and this is the step ladder of pain treatment, okay? we must be fair to ourselves. We must be fair to the patient also. If your question is how to tell the patient that if the pain is still there, it's not your fault. We must be honest to ourselves. Have we the right treatment for our patient? If it's our fault not giving the patient the best treatment, that we don't have to say to the patient, oh sorry, I give you the wrong medication. No, don't say that, but just refer to this step ladder of pain treatment. So in the pharmacological treatment of pain session in the 4-DIP course, you will be given the way on how to treat the patient using pharmacological methods. There is NSAID, there is paracetamol, there is pregabalin, there is SNRI, there is a lot of medication that can be chosen to treat the patient to get rid them from their pain. If we go back to this one, so you can see it clearer, yang kayak gini.
Oh, beda slide.
Go back to our previous slide. This one. It is clear for you, right? If I put this, okay, make a straight line down here, okay? This is the patient's, this one belongs to the patients, okay? And over here to the right side, this is doctors. Huh? Can you see it? The drawing?
Share screen.
Oh, I'm sorry. Okay, so I just use the cursor, okay? Okay, see, at the 3-score scale here, downward, make a line, downward. The non-obat, the non-medicamentos treatment means the rehab, conservative treatments, and the first medicamentos treatment belongs to the patient, and also for us, it belongs to us also. But from the 3 scores above, the step 2 and above belongs to the doctors. So tell the patient, if your pain is already at the score 4, 5, and so on, this is my turn to treat you. I will use A, B, C, okay? But please refer to the wise and rational pharmacological treatment that will be given at the pharmacological session at the 4-NIP course, okay? If you've already given the optimized treatment, that you may say to the patient, okay, be patient. You are in the treatment of my medication treatment. If then in 1 week time, 2 week times, the pain is still there, I will change it a stronger one, or I will combine it with another medication. Okay? But please keep in mind, do not let the patient in suffering for a longer time than 1 or 3 months. Depend on the medication that is given. There is an optimized standard time for you to be rational, to say to the patient that you are still trying to cure them. Okay? Mostly in 1 month time, the pain has already resolved. Except for neuropathic pain. Maybe you need 3 months time. So if the treatment is already given in 1 month time and the pain is still there, please keep in mind, maybe you need to refer the patient to the IPM doctors. Or if the neuropathic pain happens, maybe you need 3 months. Keep them with you for 3 months, it's okay. But after 3 months, you must think about another treatment. But in my previous case, the pain is resolved without giving interventional pain management. Why? Because maybe the patient at the previous visit to the other doctors doesn't follow the doctor's instruction, doesn't take the medication, so she doesn't get the optimized medication. But in my way of treating the patient, you can see that in 3 weeks' time, the pain is not there anymore, only still a bit the tingling sensation that will need pregabalin treatment for 3 months. After 3 months, I must stop the pregabalin by doing tapering off. Okay, but if the patient still suffer from the pain after my treatment for the piriformis syndrome in, for me, not more than 2 weeks' time, I will think about the IPM because the suffering has already been there for 7 months. Is that your question? Have I already answered your question?
Answered your question?
Okay.
Okay. I think we should move to another question. We have another question from Dr. Lisa. Thank you, Dr. Novy, for the good lecture. I have a question. What is the purpose of WFE? William
Okay.
Flexion exercise. Is it to stretch the back muscle or to reduce the entrapment from spinal stenosis? And when is the best time to give our patients the exercise? Is it as soon as possible when we find there's spasm in the back muscle, or we have to reduce the pain scale first?
A lot of questions. Oh, yeah, okay. William flexion exercise is a rehab exercise, one kind of rehab exercise. I give the William flexion exercise for mostly of my low back pain patients. Actually, the exercise should be given tailor-made. Tailor-made means that specific muscles should be given specific exercise also. But in my pain clinic setting nowadays, I don't have the strength, I don't have the energy, I don't have the time to do specific treatment. So all lower back pain muscles, low back pain patients, I give them William flexion exercise after the pain is resolved. So if the question is when to give the exercise, as soon as possible, no. Once the pain is not there anymore, at least the pain scale is only 2, then I give the stretching exercise using the William flexion exercise. So if there is still spasm, there is with pain more than 3 numerating rating scale, I don't give and I don't suggest you to give the patient such exercise. It is given to stretch in the piriformis syndrome patient is to stretch the piriformis muscle. So if I have time, I do specifically the stretching for the piriformis muscle. But for the general population, I give just the William flexion exercise and it's enough. Okay, and is there any question related to the William flexion exercise? To stretch, yes. And also I give the strengthening exercise to the back muscles and abdominal muscles also. If it is used to reduce the entrapment from the spinal stenosis, no. The best time is when the pain is already no more there. Can we give the exercise as soon as possible? No. When we find there's spasm in the back muscles, or we have to reduce the pain at, yeah. The answer is we must reduce the pain first till less than 3. Okay?
Okay.
Okay. Any questions?
Yes, there are some more questions.
Some more questions, but maybe I want to show you first the other case, okay? So you will have a wider way of thinking about how to treat the pain, okay? You can ask me further in the WhatsApp or in the next lecture, okay?
Maybe after this case also.
Maybe after this case also.
Yang PHN.
PHN, okay. Because there's question about post-herpetic neuralgia. Okay, this is the fourth case actually, so I skipped the second and the third case. There's a male, 69 years old, came to me. He was a retirement man. He complained of pain from the flank, right flank here, referred to the anterior abdomen for 6 months. And he was diagnosed herpes zoster at the 6 months time previously. So there's history of herpes zoster 6 months ago with hypertension and diabetes mellitus. He has already consumed amlodipine for the hypertension, candesartan for the hypertension, metformin for diabetic, and he took 3 medications for the pain from an internist, but can't remember the drug's name for 1 week. The history of treatment, that. Okay, and from the from the history taking, the pain has already suffered for 6 months. There are no numbness, no tingling sensation, no burning sensation. He can sleep at night. He often felt the pain, but sometimes the pain is gone. No burning sensation?
Oh, there are burning sensations.
There was burning sensation, okay? Because herpes, post-herpetic neuralgia usually cause burning sensation, pain, like pins and needles. Sometimes there also, and even frequently make the patient cannot sleep at night because of the pain. And I have a patient told me that I dream about having pain at my back, and I woke up suddenly and there is pain. You remember that, right? Okay, this is the picture of him. The rest you can see here from the lower abdomen to the back here, more or less at the level of thoracolumbar junction area to the abdomen and inguinal area. There's allodynia at the side of the rest. Okay, so the working diagnosis is just simple, post-herpetic neuralgia at the level of T11 till lumbar 5. Lumbar 5? Okay, lumbar 5. Actually, if we see the rest, it stops at lumbar 4. Oh, till the bottom, okay? Till lumbar 5. Okay? So the program is I give him caudal epidural treatment using ultrasound as guidance. And after the caudal epidural is done, the numerating rating scale becomes 0 at the time. And I give him pregabalin 50 mg once a day at night, tramadol, paracetamol once a day also at night, mecobalamin. Because it is neuropathic pain, I always give the patient mecobalamin 2 times a day, and lidocaine 10% ointment, and ask him to visit me again in 1 week time. Okay, in 1 week time, the pain is already reduced to 50%. So from the objective is still the same, but improving already. So the assessment, the diagnosis is still the same, PHN improving. The program continue the pregabalin 50 mg at night because the progress is quite good. If the progress is not good, I will increase the pregabalin. And I plan to maintain the pregabalin for 3 months because the mechanism of action of pregabalin is by make stable the ion channel in the nerve membrane. So after 3 months, hopefully the habit will be there. So the pregabalin will not need it anymore. Okay, so I plan to give the pregabalin only for 3 months. The mecobalamin continue 2 times a day. The tramadol, paracetamol just when needed by the patient. I give citicoline 500 mg 2 times a day, and lidocaine 10% if needed also. Okay, so this is just to remind you again about the step ladder of pain treatment. Okay, please remember to give the promotion and prevention to our patient, and remember also about this pain assessment tool and the step ladder. Okay, so answering the question of Dr.
Muhammad Rahman. Yes, so he asked whether IPM management is available for post-surgical neuralgia, and you have the answer that
Yeah.
yes, we can do IPM for
We can.
PSN.
But once we are dealing with the neuropathic pain, it is quite challenging. Not always the rating scale becomes 0 after the IPM. Very frequently, we still need the medication, especially the mecobalamin, citicoline, because we need to maintain the electricity imbalance in the nerve involvement in the neuropathic pain, and we need to give the medication to make the healing process of the nerve injury better. And to cover the excess of pain there, we need to give him painkiller lidocaine or tramadol, paracetamol as needed. So hope you already answered. Okay, is still any question related to PHN?
No.
No. Is there any question?
Yes. From Dr. Indah Permatasari.
Yes.
Good evening, Doc. Is there any IPM management for the Quervain syndrome?
Yes, but I don't have the case here. The Quervain is caused by the inflammation of the tendon and synovial that covered the first compartment of the extensor tendon at the hand. There are 6 compartments here at the dorsum of our hand. Camera, please. This is my left hand, okay? This is the far side and this is the dorsum side, okay? At the back of our wrist and hand here, there's 6 compartments. The first compartment consists of APL, APD, abductor pollicis longus, and extensor pollicis brevis, which acts to abduct our thumb here. This is adduction and this is abduction. So the function of abductor pollicis longus is to abduct the first digit, to abduct the thumb, and the second one is extensor pollicis brevis. This is flexion and this is extension. So the function of extensor pollicis brevis is to extend the thumb. So there will be pain when the patient is asked to extend the thumb, to abduct the thumb and to extend the thumb. Okay, there will be pain and the pain will be felt here at the area of the first compartment of the wrist extensor here. Okay, and it will be felt more when the tendon is stretched. Okay, the tendon is to do abduction, so we do the adduction. The tendon is the function of the tendon is to do extension, so I do the flexion. So I adduct the thumb and do flexion, and I press it, and I provoke it like this. Can you see it? And then pain will be felt more, ouch, here. So by the symptom and sign, it is positive, the Quervain syndrome. If the pain is just happen for 1 day, 2 days, 1 week, you can use the rehab conservative treatment either with or without medication, depending on the severity. but don't let the patient suffer for more 3 days using rehab treatment only. Please give some NSAID to reduce the inflammation, because if the inflammation is there for longer than 1 week time, the suffering will be more. So give the NSAID plus the rehab modalities, and don't forget to give the patient resting from the abduction and extension movement of the thumb. Means maybe you need the patient to be given splint, the Quervain splint, so the patient cannot move her or his thumb like this. Okay, rest the thumb. Always give brace protection by splinting, resting. Okay, and then icing, give ice there. Cool modalities, cold treatment, and then price, PRIC, compression, compress it, and then elevate it higher than the heart. And then please give your rehab treatment, give NSAID, C in 1 week time, 2 week time. If it is just happen, then it will resolve sooner than if it already become chronic. If it becomes chronic, then we'll need IPM to make the patient get rid of the pain sooner.
I hope that answered your question, Dr. Indah Permatasari. And we have another question about PHN from Dr. Rahman Wijaya. I want to ask why you choose caudal epidural for this case. Why not block the nerve?
Which nerve to be blocked? The involvement is T11 till L5. Okay. The mechanism of post-herpetic neuralgia is because the virus is being dormant at the dorsal root ganglion here. Okay, so go back to the mannequin. This is my friend. The camera, please. This is the bulging here that is called the dorsal root ganglion. It is presumed like that. It is hypothesized like that. Once the condition of the patient become low because the immune is reduced, because of illness, because of immobility, or something like that, then the virus will become active again, and the illness will follow the radix of the nerve root. If this is T12, then it will follow the T12 dermatome from the back to the abdomen. Okay, if the dormant site is at the T2, means it will follow the dermatome of the L2. So depends on which nerve root we must treat this nerve root actually. But it has too many levels, T11, L1, L2, L3, L4, L5, 6 levels. Why? While the symptoms is actually neuropathic. Neuropathic means not only loss of sensation or reduce of motoric component, but neuropathic component such as autonomic involvement. There is allodynia. Allodynia means that there is adverse reaction of the nerve, which cannot be helped by doing blocks to the nerve root. Here, we must block the sympathetic component of the nerve, where the component of the sympathetic component of the nerve is at the dorsal root ganglion, at least there. So we need to reach it either to the transforaminal or from the epidural. Epidural can be reached from the here, from the lower back here, but you must approach it one by one. Well, actually, the autonomic, the sympathetic and the parasympathetic component is deeper there. So it is wiser to give the epidural block inside than to the dorsal root ganglion. So it means usually either you give the epidural or the paravertebral block. It is evidence-based medicine said, not by me, but by the research. So give the epidural or paravertebral block. You can try to give the nerve block, of course. For example, if it happens to the thoracic cage area, you can try to give intercostal nerve block. But intercostal nerve block only cover the nociceptive pain, not the sympathetic component. So if it already reduced the pain, fine. But if the pain is still more than 70%, please go further to the central, means to the epidural or paravertebral area. Very good question, Dr. Rahman. Thank you.
Thank you, Dr. Rahman Wijaya. I hope that answered the question. We have another question from Dr. Meli Anggania. Dr. Novy, how about pain after stroke attack? When rehabilitation will give to the patient, should be given to the patient?
Post-stroke pain. Post-stroke pain, thank you, doctor. Post-stroke pain can be nociceptive pain, can be neuropathic pain. Which one that you are asking? Nociceptive pain can be caused by, just like non-stroke patient, it can be caused by frozen shoulder, it can be caused by stiffness of the joints because of immobility. For example, if you have a stroke patient, usually the position is like this. Please turn off the chat box. Thank you. Okay, the camera to me, please. Okay, the position is usually like this. Okay, like this. If the spasticity caused the patient position of the hand is like this, and they don't get the physiotherapy, don't get the rehabilitation exercise, then it will be stiff like this. Several days ago, we have the patient like that, right? And when the physiotherapist, when the physiatrist give exercise to him, he doesn't want to do it. Why? Because when the doctors try to just open the fingers, just to relax the wrist, just to open the elbow, it is so painful. So who wants to be in pain? Nobody. So what you have to do is to give gentle exercise since the first time. Not let them have the position for longer than 1 month time. It will be stiff. Once it is contracture, then we cannot do anything related to rehab. We must refer the patient to the orthopedist to release the shortened tendon here at the hand, at the wrist and hand. So then the muscle, the tendon can be resumed the minimal functional range of motion of the hand, wrist, elbow, and shoulder to be in normal function. But if it is still stiff, what we can do is do gentle stretching exercise without too much pain using rehab technique. There's tapping, there is icing, there's a lot of technique that can be done to help the patient to be stressed but not in too much pain. That's one case. But if there is inflammation of the supraspinatus, for example, so we can give medication and say we can give the IPM. But if then it is about thalamic pain, central post-stroke pain, what can be done actually is to interfere to the brain. But what we can do as interventional pain management doctor is by cut. We go back to the pain pathway. We bypass the pain pathway before it reaches the brain. So we can do, in my experience, is to do sympathetic block. depends on where the pain happens. If it happens at the upper extremity, we can do stellate block because the source of the pain is here at the brain, right? At the thalamic area usually. So we can block it at the sympathetic chain pathway here at the sphenopalatine or at the lower back at the sympathetic lumbar area. So depends on the source of the pain again. Because we are not blocking the pain, we must treat the source of pain as much as possible. In thalamic pain, we cannot reach the brain, so we bypass the track, the pathway of the pain. So means we are not treating the brain, so we are doing masking effect actually. So once the blocking effect has reduced, we must repeat the block. But if the pain is caused by frozen shoulder, we are treating the source of the pain. The pain will be normal once it is healed. But the thalamic pain will be there again after the block effect is gone. Okay, so depends on what is the source of the pain in the stroke patient. Treat the patient as the same non-stroke patient. So assess the patient, make a sharp diagnosis so we can give the best treatment for our patient, including the stroke patient. Thank you for the question.
Okay. Thank you, Dr.
Welcome.
Okay, for the question. And next one is question from Dr. Regina. Hello, Dr. Novy. Such an amazing explanation. My question is, would you please share your experience on pain management in children with IPM method? Does the approach of treatment is the same using the step ladder you share, or is it more considerable to treat children using the IPM at the first time? Thank you, doctor.
Yeah. Thank you. Actually, children is not a miniature of adults. So there is specific consideration in treating pain in children. But depending on the diagnosis, means depending on the source of the pain, we can treat them as the same as the adult. In the previous FIPP session, I've shown you about the CRPS patient, 13 years old boy.
Oh,
Do you remember? Okay, I hope there is still the case here. That's here. 70, 30 moment. I still remember this one.
Oh, yeah.
Okay. This 30 years old boy suffered from strong pain in arm and feet. And he couldn't walk and has been treated by neurologists, by pediatrists. And unfortunately, because they said that you cannot be treated, maybe you have psychosomatic problem, and the boy heard it. What a disaster to him, okay? And his parents is asked to go to psychologists and psychiatrists because the doctor said that this boy suffered from psychosomatis. When he saw me at the first time, the parents were surprised because they said that they know me from the banner in the lift, at the elevator at the hospital, and they wonder why the doctors didn't refer their boy to me. Yeah, I said that I don't know. At the time, my diagnosis was CRPS, and the treatment is just usual CRPS. I give a stellate block and something like that, and the patient can walk, but they require rehabilitations because the immobilization has happened already for 3 months. And the worst thing that the boy doesn't want to go to school because he is embarrassed. He felt ashamed because the doctor told his parents that he has psychosomatis. So be careful with our statement, be careful with our diagnosis. If you don't know, please don't say something that make your patients be in such a disaster. I need time to make him go to school. Okay.
Thank you, Dr. Novy. I hope the question is answered, Dr. Regina. And there are another question from Dr. Luciana. Thank you, doctor, for the great lessons. I have a question. How about topical analgesic when we could use it? Thank you, doctor.
Of course. Topical analgesic is quite good. Stepladder again. Stepladder with our today's session PowerPoint. So you can adopt my style if you want. It helps me a lot. Hope it will help you also. Please use this in your clinic, in your daily practice. Okay. Where is the topical treatment? The topical treatment is here. It is I consider it as a non-medicamentous treatment, but actually it is medicamentous treatment. Sometimes, if you have ibuprofen gel, if you have diclofenac gel, you can use it here. Okay, but if you have eucalyptus, you have menthol, you are using it here also in the zero step, and it helps a lot, especially if the pain is just below 3, and if the pain is already 10, it helps also, because the zero step, the first step, maybe still helps you in the whole score of pain. So please use it if it helps. If it doesn't help, do not use it. If you rub your back of your patient, it helps also. By talking, by giving him advice, by giving him encouragement, it helps also. So use everything to help the patient, including the topical agent.
Thank you for the answer, Dr. Novy. I hope that answered your question, Dr. Luciana. We have another question from Dr. Gutama Arya Pringga. Dr. Novy, would you please share your experience in treating diabetic polyneuropathy? Thank you, doctor.
Thank you. It's a very good question, and it's quite challenging case to treat. Diabetic neuropathy, polyneuropathy. Considering the title of the disease itself, diabetic is already a hard disease to treat, right? And has a lot of complication. Talking about neuropathy, it is challenging case also. And polyneuropathy is even harder to treat. Okay, so in interventional pain management, not talking about the conservative treatment, it is quite challenging also. If you have already treated the diabetic polyneuropathy case using the rehab and medicamentous conservative treatment and still fail, you can think to jump to the interventional pain management, but still usually we need the conservative and rehabilitation conservative treatment. So we must work together hand in hand, and it includes also if the diabetic polyneuropathy then has already involved the kidney, the eye, the heart, the patient has hypertension and a lot of comorbidity related to diabetic mellitus, then maybe the patient will come to a depression state. Then we'll need another treatment that will cause another burden to the kidney, another burden to the heart, and to the whole body. Means that we have again to work hand in hand. I as a pain physician, I as a physiatrist, I need the internist, I need the neurologist, I need maybe the eye surgeon to do the operation. Maybe I need the psychologist to cover the depression. Maybe I need the psychiatrist to help the patient with the psychiatric drug. So it is a biopsychosocial treatment to help the patient. Okay, talking about the interventional pain management, the best way, if all the interventional pain management treatment is failed and all the rehab and medicamentous treatment is failed also, maybe we can use the spinal cord stimulator or peripheral nerve stimulator. It is the best now, not the best, the other choice to help the diabetic polyneuropathy 1. So, please think wider. Don't let the pain suffer too long and too much. If we can refer the patient to other doctors who has the skill to do it, please do it. Okay?
Thank you, Dr. Novy, for the answers.
Is there any question?
I think no,
No?
for right now.
Okay, right now there's no question. How many minutes left? 5 minutes. Maybe I will show you another case. The first case has already been talked. What case do you want to see? There's a lot of cases actually. I let you to ask and I'd like to answer you first before I proceed with the case, because I know that you want to know more. Okay, so it's better that I let you ask and I answer you. But if you have question when I show you the third case, please feel free to ask, okay? The third case is about a female 27 years old banker whose ADL is independent, and the chief complaint is pain from the upper to the lower back, and she was diagnosed SLE. SLE is systemic lupus erythematosus, autoimmune disease. Okay. The symptoms was felt at the upper back, lower back around 1 week. Can't sleep in supine position. She must use a lot of pillow under her upper back to feel comfort when sleeping. There was no numbness, no tingling sensation. There was no incontinencia, no defecation disturbance. The numeric rating scale was 7 to 8 in the scale of 10. There was no history of allergy. History of past illness is gastritis and SLE since means 5 years back, right? There's history of drug consumed since 5 years ago, methylprednisolone 8 milligrams 2 times or 1 time a day.
8 milligrams in the morning and 2 milligrams in the night.
Okay, myofortic 2 times. What is myofortic? Vitamin D and calcium. Okay, the differential diagnosis is, of course, the SLE, but for me, it can be MTPS, myofascial trigger point syndrome at the upper back, cervical facet arthropathy, or lumbar facet arthropathy can be, right? So I go to the physical examination after the history taking. At the head and neck area, it is symmetry, no atrophy, no inflammation. There is pain when she did bending to the left side, and it is felt at the paravertebral cervical area here. Okay, and there is trigger point at the left upper back area. Swirling test negative, distraction test is negative. There is pain on pressure on the paravertebral cervical area at the level of 3, 4, 5, 6, 7 left side, right side, but the pain is felt at the left side. So sorry if it is a bit confusing, okay? Because there's a lot of patients here and we try to show it to you, okay? The numerating rating scale is 7 to 8 in the scale of 10. At the upper extremity, abduction, flexion, all range of motion is full, no pain felt there. Hawking Kennedy test is negative, both sides. Belly press test was negative also. Okay, so the differential diagnosis from the history taking and the physical exam is myofascial tiger point at left side. So means that previously pain on pressure right side. Okay. And cervical facet syndrome C3, 4, 4, 5, 5, 6, 6, 7 right side. So the myofascial tiger point syndrome is at left side, but the cervical facet syndrome at right side. Okay. The problem is, of course, again, after we have the diagnosis, we want to treat the patient, we must list the problem, set the goal, so we can give the patient the best treatment. The problem is pain and vocational. The goal is to reduce the pain. We can list more than this problem and more goals, depends on you if you have time, okay? But mainly is this one, to reduce the pain, to increase the quality of life. The management, at the time I give her dry needling. After the first dry needling, the numerating rating scale decreased 50%, and she refused to taking medication. Okay, so I gave her the dry needling every day. At the first follow-up, she felt much better than the previous day, had better sleeping time. At the examination, at the head and neck area, all the range of motion, flexion, extension, bending, rotation is full, no pain. Happy. I was happy, she was happy. The assessment is just the same, but already healed. But I continue with the dry needling because she doesn't want to take the medication. I give adjustment to the steroid to just 1 times 4 milligrams. Previously 2 times 8 milligrams, right? I reduced the steroid to just 1 time 4 milligrams, and I changed the steroid to the celecoxib, 2 times 200 milligrams. Okay. At the third day, there's no pain at the upper back area, at the head and neck area, just the same at the second day. So the assessment is still the same. The program, nah, this is related to the question from Dr. Linda. When to give the patient exercise? Once the pain is not there, give the patient exercise. I gave her neck collier exercise. Neck collier exercise is just follow the range of motion of the neck. Just 3 pairs, flexion, extension, lateral bending to the left and to the right, rotation to the left and to the right. But you can do it with or without stretching exercise, okay? Sorry. No, my... Okay. Okay, combining with aerobic exercise because the pain is already almost no pain at all. Because once you are immobilized, the pain will be there sooner compared if you do exercise. So neck collier exercise just involve exercise to do the stretching to the neck muscle and upper back muscles, and I gave her aerobic exercise because she needs to do the aerobic exercise to push the blood to her whole body to make her fresher. Once we do aerobic exercise, we means that we trigger the release of endorphin from our brain. The endorphin is a kind of morphine, you know it already, that will reduce the pain. So it is good to relieve the pain, to give relaxation, to make you happier. Nobody with morphine addiction will be sad, right? And then to strengthen the whole major muscles of our body. So I gave her the aerobic exercise and give her proper body mechanic because she works at the desk because he is a banker. Not to give tension too much to the body. So I give prevention to the patient, not letting her getting the pain sooner, okay? Too soon. And I give her dry needling 7 times more while tapering off the steroid. And that's it. So what's called by giving her the patient's curation method, prevention method, promotion method is just like this. Okay, so I don't give her IPM. I don't give her too much medication. Instead, I reduce the medication and stop all the medication and stop also the dry needling and let her live her life peacefully and healthy and with a healthy lifestyle as well. Okay, is there any question? Is there any question?
Not yet for now.
Not yet? Hope these three cases will trigger you to learn more about pain, will trigger you to have the eagerness to know more about how to treat the pain patient. Either you want to follow me to treat the patient using IPM or no, but at least you know how to treat the patient with pain wiser using the stepwise approach of the pain treatment adopted by cancer pain treatment from WHO using the simple pain assessment tool. Okay, and my education and my take-home message is just the same as the previous 4 deep session, that we must give education to our patient. So then before we can educate our patient, we must educate ourselves. So please follow us, okay? I am not the best. We are not the best. You can read, you can learn more about pain in books. But if you have time, please join us also. The first important step to make best treatment to our patients is to make good diagnosis. The second is to make good diagnosis. The third is again to make a good diagnosis. Without diagnosis, we can not give treatment to our pain patients. Why? Because we are treating the source of pain. We are not treating the pain itself. We are not painkiller. We are healer, right? And please do not treat the picture, because not always we need the picture. In my cases, in my 3 cases, do you see any picture there? No. Okay, but if we need picture, if we need ultrasound, if we need EMG, if we need MRI, please do it. But if you don't need it, do not use it, because we don't want to make our patient broke. We don't want to make our patient broke by doing wrong diagnosis. We don't want to make our patient broke by giving too much medication without any result, right? And please remember that if I show you 3 cases, not always the same case will have the same treatment. All treatment is always should be tailor-made. And please follow the step ladder pain management. And please give also preventive and promotive pain management for the patient, so the pain will not coming back if possible. If it comes back, at least it comes in not a too soon time. Okay? Thank you for your attention. Thank you for your joining us. Hope you have a wonderful time tonight and tomorrow, and hope you have wonderful time with your patient. Hope you have a better way of thinking about how to treat our patient, to give the world a better place to live, to give the world a pain-free
World free from pain.
Yeah, this is our newest motto, to make
The world free from pain.
from pain, to give the patient a better quality of life.
Okay. Thank you so much, Dr. Novy, for the lecture. It's so interesting. And thank you, doctors, for all the questions. It's our webinar is so interactive, right? Okay, so let me conclude our webinars tonight. So pain can affect biopsychosocial patient's life. We gotta make time to listen the patient complaint and do the complete physical examination. By doing that, we can give our patient the best pain treatment. And we also need to give our patient the education about the first one is what can cause the pain. Dr. Novy always said to the patient like cinta, CINTA. C is for congenital. So if the patient has a congenital problem, so it can be source of pain. And the second one is infection. Infection also can cause the pain. And the third one is neoplasma. And the fourth one is trauma. And A is pronounced in Indonesia A, so CINTA. And the A is others. Others is the most common pain source problem in daily activity of patients. And the second ones, we also need to give the patient education about the treatment that we are going to do, the planning treatment. We must know when to refer and don't let the patient suffer from chronic pain. And the third one is we must know how to prevent the pain. So we must teach the patient how they can do the pain prevention. So please join our webinar program to learn more about pain so we can make a good diagnosis. This is our program that you can see. Okay, this is our program. So IPM is not a panacea. Every step of pain intervention is a part of holistic rehabilitation program. Pain is inevitable, but suffering is optional. And this is our clinic. Please come or visit us to learn more about pain. It's available in Bandung Pain Rehab Center, Cipaku Indah 3, nomor 8, number 8 in Bandung. And this is our program for this year from pain management. Will Dr. Lala, please, could you tell us more about the program?
Okay, Dr. Kansa. So as you know, this is our second introductory webinar for NIP, for non-interventional pain physicians, which gonna take the time in 24th to 13th of April. There will be 7 webinar series, and every doctor, the GP and specialist can follow and join this program. And these are the topics that we are going to cover. And then our biggest event for this year, the 2021 virtual conference of PainManagement.Network on 10th to 11th April 2021. We will have 45 speakers for 14 countries that gonna talk about, of course, the pain. Yeah, and there are 44 topics for GPs, for specialists, or maybe doctors who will preparing for their FIPP or CIPS examination. We also have basic ultrasound guided interventional pain management on musculoskeletal course. We have 11 webinar series from 24th of May until 29th of July. And these are the courses, topics that we are going to cover. And then we have intermediate ultrasound guided from August 2nd to October 7th. And these are the topics. And then the advanced ultrasound guided about spine. We will have 10 webinar series from 11th of October to 16th of December 2021. So this will be a really full year of lessons. And these are the topics that we are going to cover. Okay, so thank you, Dr. Novy, Dr. Kansa, and also for doctors who have joined us tonight. I hope that the experience that Dr. Novy has shared to you will be valuable on your everyday practice. So, don't forget to follow us on Instagram and also our Facebook and also our YouTube to know more about activities and programs. So maybe, that's all for tonight. Yeah, thank
Can
you
open
for joining us.
the screen?
Oh yeah, for the participants, can you open up your video? Oh yeah, we have.
Photo session.
Well, okay, we can have photo session. Dori. We have almost 130 participants tonight.
Okay,
Uh-uh.
let's have a photo session together.
Hello, doctors.
Hi, now I see your faces.
Dr. Luciana Darsono,
Hi, thank you.
Dr. Muhammad Rahman, Dr. Eka Fitriani. Thank you for joining us tonight.
Screenshot, please.
Okay, screenshot. Smile.
Smile. Hi.
Okay, Dori.
Ready all? Not yet?
Another
No,
page. Okay.
still more
More,
because
more.
there's
Okay.
a lot of
Smile
participants.
again.
Already?
Yes.
Oh,
Okay.
that's all.
Now you come here all together.
Behind the scenes
Okay.
that
We are supported by the man behind the gun here. Ayo,
Adi, Dori,
this is Dori. This is the fish. And this is Adi. This is Dr. Cepi and Bu Yuli. And this is Albert. Come. Bert. And who is going to take pictures? But please help us. Okay, using that. Okay. 1, 2, 3, cheese. 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 Cheese.
Okay.
Thank you everybody.
Thank you everyone. Good night. Salam
Good night.
Indonesia bebas nyeri.
Salam Indonesia bebas nyeri. Bye. See you next session.
18th of March on case and update.
Okay.
Bye bye.
Bye.